I will turn it over to Dr. Carter.
Well, good morning. Thank you, Juanisha. And I just want to thank everybody for coming to our meeting. And I'm going to be very brief. I'm one of the co-chairs, Dr. Ernest Carter. And we're going to have a very robust meeting today. This is an important meeting because we're going to be talking about the for most of the meeting, we're going to be talking about our community health assessment. And the reason it's so important to us, before I even welcome you all in, it's so important because from the community health assessment, that's how we determine our community actions. And our community actions need to be driven by our CCCT because our CCCT is the primary body for understanding how to get our community coordinated and for them to get to the best health, especially in a system that doesn't really lend itself to that. So now we are the key player in how that gets done. So I want to welcome you all. And if you have, if this is your first time to the CCCT, we would appreciate if you would come on camera and introduce yourself. Everybody else who's been here before, just if you could just put your information in the chat so we be sure we capture that for the meeting. But if this is your first time, if you could just give us your name and your organization. We don't have a popcorn or whatever it is. We don't have one of those things today. So we're just going to be very straightforward so we can dive right in. So is there anybody who is new to our meeting?
I am. My name is Denise Robinson with the Community Engagement Consulting Group.
Good morning, Denise. Thank you for coming. Anybody else?
Good morning. Hi, Dr. Carter. Amber Allen
Hi.
with the Prince George's County Health Department. This is my first meeting with the CCCT.
Good morning. Good to see you.
Good to see you.
Hi, I can introduce myself, Dr. Carter.
Okay.
My name is Tara Pavo. I'm the Director of Social Services at Mary Center. I regularly attending these meetings and I really enjoy attending these meetings. I love comprehensive care coordination. That's my love to do space.
Thank you. Thank you for coming. Appreciate you. Anybody else new? Okay, so we're going to go ahead and get right on into the meeting. I appreciate everybody coming. And I just started out a little bit talking about our purpose, because our mission and our vision sort of reflects our purpose. It actually reflects our purpose. We're going to empower our community. We're going to build public health infrastructure. We have to take the lead on doing this. And to tell you why is because, as you all know, you all are the people who work in the community. You know for a fact that we need better infrastructure to help people get well. Most of their health is due to the social determinants, not from their clinical state. And if we can get if we can get our community to, in harmony, move toward better health, then we're going to have a much more healthy community. We're going to have a better, better health outcomes. So please, please, please stay with us in our efforts to do this in the CCCT. And we're going to work from basically making sure we understand what those needs are. So that's why the channel, our community health assessment is so important. We have to understand where we are and where we're going to go. We can formulate really great actions from our community health assessment. And if the community health assessment doesn't answer all our questions, we have to be the people who say, well, we need to ask this question. Have you all asked that question? Have you all looked into this? Because this is what we see. And it has to, the community health assessment has to reflect that. It's very, very important. So you can go to the next slide. So having said that, I'm going to introduce you to my other co-chair who came on first and who is, we didn't get a chance to really formally introduce Juanisha Stokes to you all, but she is my other co-chair and I am her co-chair. and we work cooperatively to make this happen. And Twanisha's been serving Prince George's County Health Department for a very long time. I'm not going to go into how long. She has a lot of experience in financial oversight, but she also has a tremendous amount of experience in helping us get programs implemented in the community. She currently now is the public health program chief for the chronic disease program, and she is a dynamo. I mean, and I'm proud to work with her on at the CCCT, and she is a very passionate and very driven individual. So I know that we're going to get a lot of stuff done here, and we're excited about her coming on as the co-chair. So with that, I'm going to hand it back over to Anisha so we can dive right into today's focus.
Thank you, Dr. Carter. And I'm excited to be the co-chair and looking forward to strengthening our partnership with everyone on the call and as part of CCT. And so I won't waste any time with, all the thank yous, but I want to just say thank you again from the bottom of my heart. And today's focus is really to focus on reviewing and discussing the secondary data sources for our community health assessment, as Dr. Carter mentioned earlier. So we'll be reviewing the data sources from the 2022 CHAR, which is the community health assessment, and discuss the social determinants of health indicators that partners are capturing or the Prince George's County Health Department should analyze for the 2025 CHAR. And so with that being said, we'll go right into those discussions, which will be led by Taylor.
Hi, everyone. Good morning. My name is Taylor Palmer, for those who I have not met yet. I am in the Office of Assessment and Planning here at the Prince George's County Health Department, and I help manage our local health improvement coalition, our 4 work groups, including the CCCT. I help manage and facilitate those work groups and executing those work plans. So something that we are currently embarking on is the 2025 cycle of the community health assessment. So as Tornisha mentioned, we have been busy taking some lessons learned from the 2022 assessment, and we are curious to gather you all today. We've gone through this with a few of our work groups to discuss their content expertise as it relates to our secondary data analysis that we're going to be taking a look at with the CHA. So again, we have that quantitative piece and we have this qualitative piece. We really want to get you all's feedback today about some indicators from your expertise in care coordination and the barriers to care coordination. We want to be able to have that discussion with you all to make sure that, again, this community health assessment can be as comprehensive and tell the most comprehensive community story possible. And as Dr. Carter mentioned, we want it to reflect community. We want it to really make sure that we are reflecting those barriers and assets here in Prince George's County. And we're hoping that you all can help in that social determinants of health space and the care coordination space and help us to paint a most comprehensive picture of how we can better serve Prince George's County residents. And so to do that, our community health assessment process is grounded in the mobilizing for action through planning and partnerships. This is a framework. It's known as MAP. You'll hear us use our acronyms. We love our acronyms here. We'll use the MAP 2.0 process to guide the community health assessment. The MAP process really emphasizes commitment to health equity, to looking upstream, to looking to those upstream factors, and asking those 5 whys of, why are we seeing the outcomes that we are seeing, and taking a look at preventative pieces. And so we want to make sure that our data discussion is getting at those upstream factors so we can talk about the barriers and the social determinants of health that you all know very well, that may be inhibiting folks in Prince George's County to accessing care. So we're hoping that we can continue that discussion with you all today. Joined on the call is also Deborah Collier from the Office of Assessment and Planning. So Deborah, if you'd like to do a quick introduction, if there's anything else you'd like to say about the MAP process as well.
Good morning. My name is Deborah Collier. I'm Senior Epidemiologist in the Office of Assessment and Planning. I'm glad to be here and kind of start this conversation regarding the MAP process that we're using towards creating the 2025 Community Health Assessment. I'll just echo exactly what Taylor's already mentioned. We won't, excuse me, we're definitely embracing the MAP framework. The 2.0 version of this framework is was updated recently, and is something that we're utilizing in terms of conducting the three major assessments involved in the framework. Those being our community partner assessment, our community status assessment, and the community context assessment. The community partner assessment is essentially an assessment that looks at the organizational capacity of our community partners. It allows us to be able to better network together and collaborate together in understanding the resources and assets and goals and objectives of our community partners that align with what we want for the community health assessment from that perspective. The next assessment, which is the community status assessment, is essentially looking at some of those health indicators and secondary data sources in order to be able to assess or evaluate what the health outcomes are of the county and our residents. And that status assessment also looks at like as we mentioned, as Taylor and Dr. Carter have already mentioned, as well. It also looks at SDOH, or social determinants of health, and some of the other causes for while we're seeing some of the health outcomes we're seeing within our county residents. And then finally, the community context assessment, which is a qualitative assessment, which allows us to try to understand and get to the root causes of some of these outcomes that we're seeing in our residents. It gives us a better understanding of, and just being it essentially in order to put quantitative data into some context so that we can get to an area of being able to strategize and prioritize prevention strategies for addressing some of these health outcomes. And so that is how we'll kind of utilize those three of those in order to be able to create a comprehensive story of what's happening with the health of the county residents.
Thank you, Deborah. And so, as Deborah mentioned, you'll be seeing many updates coming out as these assessments take place and as the process progresses. And so, we wanted to give you all some context today, as you know, where we've been at with the 2022 CHA and where we're hoping to go with the 2025 CHA. And again, gather all of your feedback and also provide some updates. I'm not sure if folks have seen it yet, but the Maryland Department of Health has released their state health improvement plan. And so just wanted to give this really quick update. They have named 5 leading health priority areas, access to care being one of those, chronic disease, women's health, violence, and behavioral health. And so here is just an example of some of the indicators that are being tracked on the state side as it relates to access to care. So you can see this focus on behavioral health outpatient service recipients, focusing on the different modes of health. So how services can be offered via telehealth, percentage of students enrolled in school-based health centers. This may be relevant for some folks on the call. Proportion of persons with a usual primary care provider, average wait time per primary care first appointment, and the proportion of individuals not covered by private or public health insurance. So our uninsured populations, but then also taking that a step further to look at our underinsured populations as well. So again, these are indicators that the state has collected that we will be working with to hopefully triangulate in our community health assessment, but just wanted to lay the groundwork, give everyone some helpful context. I can include the state health improvement plan in the chat for those who may be interested in taking a look at these other leading health priority areas and more about their plans and their indicators that they are tracking, and some of those targets that they hope to address through the implementation of the improvement plan. And so again, in grounding our discussion today, I wanted to highlight this is something that came out of the Maryland Department of Health and their process for the state health improvement plan. They conducted these community input surveys, and we were able to get this data for our Prince George's County residents. So there were about a little over 250 responses to this survey. And again, we're seeing here, and the most important things that make a community healthy, it's exactly what the CCCT is doing to address. And so again, prioritizing access to affordable healthcare, access to safe and affordable housing, healthy and affordable food, low crime, safe neighborhoods. Again, you'll look through this list and you see so many of the social determinants of health and so many of the components of care coordination that the CCCT is working on. And so again, we wanted to bring this up to you all today to ground the direction of this work, some data that we are collecting behind the scenes, but then also be able to open up this discussion to you all today to see what are our gaps and what should we be considering, whether your organization is tracking specific data as it relates to care coordination, the social determinants of health, access to healthcare. We would be curious to hear that. And then, of course, you are all situated uniquely in the community. So you're seeing patients, you're seeing clients. And so we want to know what are some indicators that we should pay attention to, again, to tell the most comprehensive story here in the community health assessment. And so, as I mentioned, we'll do just a really quick recap of the 2022 CHA. You will be able to see here in the next slide, we have our specific indicators that we've previously tracked for access to healthcare. But again, we're hoping that you all can give us some feedback so we can take that up and make sure that we are, again, telling a more comprehensive story of some of the facilitators and barriers to accessing healthcare and improving someone's agency to be able to make those decisions and be able to access those resources here in Prince George's County. If you're a part of our other work groups, you may have seen this before. We've talked about, for example, substance use and behavioral health. We've talked about that with our behavioral health advisory group. But for those who would be interested in taking a look at our other 2022 CHA data matrices, we can provide that list with you all. We have a data metrics that takes a look at all of the indicators that we've used across all of these areas. And so you could take a look at that and see if there are any gaps, but we will be focusing today on this access to care space. And so to help us get your feedback today, we're hoping we can have an interactive activity. So if folks can use their mobile device, you can either scan the QR code or you can go to slido.com and you'll put in this 7-digit code 3353549 and you'll be able to join and give your feedback today. And feel free to use the chat or come off of mute if anyone is having any troubles joining this morning. And if you're joining and seeing that it's saying no active polls at the moment, as soon as I go to the next slide, it will open up. So you are in the right place if you're seeing that message. Great. Well, our first question for you all to give feedback. Our question here is, what other indicators and data sources could be included to better assess access to care? So here you'll see our graphic. It is tracking the data sources that we previously used in the 2022 community health assessment. So again, we're looking at residents with health insurance, adults who had a routine checkup in the last year, residents with a usual primary care provider, and resident to provider ratios. And then here at the bottom are those indicators that the state is tracking. But what is missing from this list? What do you all think that we should pay more attention to? What's missing here? Or what is your organization tracking?
Can everyone see it now in their app? Until I'm not able to see it in the app.
Yeah, it's
Just
not
make-
coming up for me, Taylor.
Okay, the question or the image?
None of it. It
Yes.
says there's no active polls. There it goes. Now it's there.
Yes. Mhm.
So our first responses here, looking at the hospital emergency room, avoidable hospitalizations or repeated admissions within 30 days of discharge, number of people in the household. For anyone who has submitted a response so far, would you like to expand or talk through any ideas that you have?
It looks like a couple of us said hospitalizations. I wonder if any hospital people are on who have like, I know there's measures associated, and Dr. Carter, you might know too, with like I guess not preventable hospitalization, but like there's the hospitals have their measures about like hospitalizations that are associated with maybe not having access to care or not providing care coordination. I felt like it was readmissions.
That's what it's been, Caitlin. Readmissions has been a big thing for hospitals in the past. Absolutely. I don't know. I'm not sure if there's a hospital person on here that could further delineate that. I was one of the ones who said hospital ER too.
All right, we're on the same page.
Yeah. No, well, I mean, when you think about it, one, of course, is the readmissions and them going back and, continue to go back to an ER. They may not get admitted, but they'll go back to the ER, whether it, for whatever the reason is. But, I fortunately I broke my ankle, so I was back and forth between the ER a couple of times a couple of years ago. And my observance was the amount of people that are waiting to even be seen in the ERs. I see that as huge, and having an understanding again as to, we've created and we've brought on urgent care, to help with appropriate people going to the ERs, but many times getting back to even the access of care when it comes to insurances, whether it's private or public insurances, people don't have that insurance. So I'd be really curious as it relates to hospitals and their ER visits. How is that going? Are they seeing less ER visits or less people that are uninsured? Are they seeing more people that are uninsured? I mean, that kind of was what led me to my whole thought process.
And I see some folks have talked about insurance coverage and private versus commercial Medicaid enrollment.
Well, and I'd be curious, and maybe there is a place, but because we see information from hospitals, we see information from different things, but the MCOs, where do we see information about the patients that they're seeing? Where do we see, what are they required to have some of the same measures, and how are they doing with those measures? How are they doing? I know that, because I work with primary care now, and I know what primary care providers doing with some of them, not necessarily MCOs, but more with Medicare on the quality measures. But I'm just really curious. I don't see a lot coming out about MCOs and how they're doing with their quality measures. Maybe there is, I just don't see it.
I don't see it either, so I'd be curious too, but I guess I'm not in it like I have been in the past, but I haven't seen it either.
Yeah,
To,
I mean,
to your point.
we're really good at holding Medicare to the fire. We can see a lot of the commercial, measures, whether it's Care First or some of the different ones that they're better. But the MCOs, I have, and I would think I would see some of that, and I have no clue.
So maybe that's something for our team to hunt down. We need to just to make a note of that.
So we're seeing now talking about new cases of chronic disease. We have preventative care, specialist ratios too. So going beyond just the primary care ratios.
And even honestly, if we're being that inquisitive, what's going on with the urgent cares? I don't know if they have to. They're probably, but there's a number of urgent cares that are tied to the health systems. A lot of them have urgent cares, and it may not be something that's reportable. I don't know, but it's just, if we're trying to get a really understanding about access to care and how it's all going, I think that's an important piece too.
No, I really agree with you. See, we talk about hospital utilization, but we really should be talking about healthcare utilization indicators. And that
Yes.
includes the
Yes.
hospital, the emergency rooms, primary care visits, prevention care visits,
Yep.
urgent care visits, vaccination screenings, all of those things. I mean,
Yep.
we look at those rates, and we really need to be looking at like the preventive care rates. Just how many people are getting screened for X, Y, and Z. I mean, immunizations, or we need to have a holistic look at
Yes.
healthcare utilization, because the when we did the health enterprise zone, the hospital utilization only told part of the story. But then when the community health workers went out there and started doing stuff, you got all of these. It told a big story. It said, "Oh my God, some folks didn't go to the emergency room, but they have done X, Y, and Z. Or they're taking their old pills, or they're doing X, Y, or Z." So the hospital utilization are a certain subset of folks. Then there are people who don't use the hospital, but and just out there getting sick. And we need to understand the entire picture of healthcare utilization. And so that's an important point you all have just brought up. And I think I mean, I don't know if we have a real good grasp on it, but we do need to get into those indicators. Does that make sense? I appreciate the discussion.
Well, I'm wondering if Medicaid, from a state perspective, would have some of this information, in particular about the MCOs, and would they be willing to share? I don't know if anybody has a relationship with anybody there.
We have the Associate Director of Health and Wellness on with us, and she has all kinds of arm strength with the state. So we'll get that. We'll get that information.
I don't know about arm strength, but I can always try.
I just think back to Dr. Carter's point is trying to build a fuller picture. We've done a pretty good job through the years, but I think that as we try to really understand what's going on with what's there, I think there's just some missing pieces. That's all.
Yeah, they're definitely missing pieces. That's why this is a discussion about what indicators and data sources we need better understanding of, even to the point of just how many, we understand how many healthcare providers we have, but it could be that the way our health systems facilities are distributed in the county. It could be geographic location. It could be there are healthcare shortage areas that we don't have adequate transportation to, and I know all those things are there, but we have to think about it like, for instance, if we're looking at the transportation variable, we have to understand how the transportation variable affects the access variable. That does it, and how do they interact? So some of it, when we're looking at those indicators, for us to design projects, so at the end of the day, what we want to do is make sure our community health workers and our programs are optimally mitigating the access. The access is what we're trying to improve. We want to be sure that our placement of our how we go about doing care coordination can help mitigate that access problem. And to do that, we have to understand, not only how, those indicators that are telling us how they're utilizing the healthcare system, but also those indicators that tell us whether or not there are adequate providers, et cetera, and what is the difficulty in transportation? I mean, because at the end of the day, it's going to be money. And when you talk about access, it's going to be money. So we got the financial barriers. We need indicators to tell us about that. It's going to be where are they located in transportation. So it's like geographic sort of indicators. And then it's going to be, whether or not people have education levels and housing and all that. And then, of course, we can get into the equity discussion, language barriers and all that. But those are going to be it's going to be those mash of indicators that make up what community health workers actually see every day. I mean, they are looking at it and they're trying to solve these problems. And we have to understand the baseline indicators for that. So there's a lot of indicators in this space, I think. And the question is, if we base our efforts on on a few and not take a comprehensive look, I don't know if we get to where we want to go. But we should sort of think as many of these indicators and data sources as we can think of, and then we may have to prioritize. But we do need to try to get them all sort of in view. Does that make sense?
Yes. Another question is, when you speak, Dr. Carter, regarding the CHWs, are there reports on, is that information available about, or even when we're working towards findhelp.org, working with that, will that information be looked at and able to use to help make some decisions too?
That is a good question.
I'm sorry, guys.
I don't know how to answer to that. I don't have the answer. If the answer is no, then we have to work on getting that done.
Yeah.
So I'll have to let Twanisha and Caitlin talk about that.
My two friends won't want to talk to me anymore.
No, we can never not talk to you, Judy. Go ahead, Tanisha.
Okay, so we've been meeting with Find Help, CCT, and the Healthcare Coalition Group as well, to look to see how we can leverage Find Help and to make sure that our community partners are connected and make sure that they're, updating their information. And of course, there's funding piece when you want certain reports, because there's a free component of Find Help. And then if you want additional reporters and additional features, there's a cost. So we're looking into that to see what does that look like. And we're learning from other partners who's using Find Help, and that has been very productive in their counties. So we're taking their lessons learned and, applying that to the information that we have to see how we can move forward with having that type of capability within Prince George's County. So that we'd be able to share those reports, Judy. So yes, We're looking into that.
Thank you, Tornisha. What about our own CHWs and what, the reporting, and how can that be what they're doing and working on? Could that be used to impact, what we're doing as far as access to care and understanding? Do we have anything on that?
Caitlin, start. So we are captioned because we have so many projects and we're using it for different projects. So yes, we're using it for preventionally. And then also I'll let Caitlin speak about CHIS, as well. So.
Yeah, I actually see Mike came off mute, so I'm going to defer to Mike. Do you have any?
Sorry, Mike. I'm sorry.
No, it's okay. He's the data guy. So I'm gonna give him the floor.
Yes, we collect all this data and they are available. We can share with, and people can know what exactly CHWs are doing. Yes.
But not just even what they're doing, but where are the needs? I think that's possibly,
yes.
What would be so beneficial is to see what where are the gaps? And again, it gets back to what I'm thinking about with practices, and I'm talking to them about gaps in care. Well, it's the same kind of thing with CHWs. Where are the gaps in care for them as far as when they're working with these patients?
Yes, we
Yeah.
do have that. We have the list
That's
of the
cool.
needs, and also we collect like what are the needs, the CHWs can meet easily and what needs they can't, in our county, which is difficult. And the one, they might help. So we have three categories of needs. There are things they can definitely help, things like food and like transportation. But when it comes to housing, it becomes a little bit complicated. So we have all this data.
Yeah, and that I think sharing that information with this group will give a good understanding of what to understand and what are some next steps, possibly, depending
Good
upon how you
idea.
guys want to put that together.
Thank you.
We actually have a table that our most recent evaluation for um the whole project period or the whole grant that shows like referral completion, so referral numbers and then referral completion rate for each type of referral. So I feel like that could be really good information because some of them are really low.
Yeah.
Yeah.
I'm curious on the topic of reports, what are folks currently accessing? So Dr. Carter named a bunch of barriers to care, so to accessing care, such as transportation, finances, education, health literacy, housing, language barriers. What are folks accessing in terms of secondary data? Where are you getting this data from? If anyone has any suggestions off the top of their heads for where you're accessing information, whether it be for a grant or a report. I know I see TLCs on the line, our community engagement consulting group. What sources are you guys using?
And I can start, then you can chime in if someone don't want to start first. So, I know for us, we use, of course, the community health assessment. We go to the PG Health Zone, of course, Chris, and also, the state of Maryland to their resources as well. So there are some areas that we go to pull our data.
Any other sources folks want to name?
This is on another project that I'm doing with HQI, but I do look at the hospital community benefits reports. What's going on with them and what their priorities are. And that would be an interesting thing to see how the priorities that the state has talked about and the priorities that, we talk about for Prince George's County, and then how those priorities work together with what the health system chooses to. I think that we'll get a whole lot more bang for our buck if we're on similar priorities.
And then I know back to the MCOs, I know once we, finalize our BAA, some of the MCOs was agreed to share some of their data. And this was really focused on our family-based behavior therapy treatment program. But they was, able to pull analysis to show which zip codes, which providers, and the rates of the percentage of participants that was eligible for our program.
Tonisha and Judy. All right. And just in the interest of time, I want to get folks' feedback really quick on a few other of our social drivers of health. So next we have social and community context. So if there are any specific indicators or data sources that weren't previously named that folks would like to mention here.
Well, to give you guys a little context to that as you all are doing it. So this question, this indicator, which I think this was the one, this is the indicator, this is not better access to care. You're at the next one, correct? Which one?
Correct.
I'm sorry.
Yes, we're on the social and community context.
Yeah, so you should, okay, so you should
Okay,
advance
it's a
your
different
slide. So
slide,
that people,
sure.
yeah, just advance the
Okay.
slide one so that they can see it. Yeah, so this one, just to give you a little bit of context, some of the indicators in this area could be, how many community health centers are in a given location, or do they what does their family structure look like, and do they have social support? How do we have ways of measuring that? Of course, their marital status and stuff like that. But you want to be sure, we want to have some kind of sense, because this is a huge piece of why people don't have good health care. It's their social and community context. And I was just having a discussion with Caitlin about this, because people who are lonely, who feel socially isolated, their health is really bad. They don't have great health care. So do they have enough social capital? I mean, do they have civic engagement? Are they part of something? Is there a lot of crime in their area, so they will be that their health and safety rates because of where they live affect their overall health care, or how are they connected? This is really is an important piece, and the indicators here, I'm not all clear about, how we measure that. So, but I really need you all's input. But we need to know this. We need to have a really good idea, because when you're putting a project together, like if you're a FQHC and you're putting a project together to increase your overall outcomes, and you're using the care team, this is a tremendous piece of information that you're going to need as your baselines to be able to overcome some of those barriers. And I know, and this is from our experience. I mean, this is, it's not that, we're making this up. This is definitely from our experience, that this is a huge piece. And the other part of this is education and literacy. We got to be able to measure that in the community, because we're lumping these things into sort of social context, social determinants of health. But they're really, but they have an effect. Like I said, these different indicators have an effect on each other. Like your literacy has an effect on whether or not you have stable housing, on whether or not you have loneliness. All of those things sort of interact. So we need indicators of all of these things. And that's why we really need your help in making sure we're defining those indicators, because, your cultural context, is that affecting it? Is it your housing? Anyway, I'm saying all this. At the end of the day, it's your community support services. Are they there? Yeah, are they helping you? Do you have? We always talk about a provider, a decrease in providers in a zone, but do we have a decrease in community support in an area? Do we have the indicators that help us understand how they can access social services? The interesting thing about social services is that, we have to understand, are we optimized in terms of where people can go and get social services? I mean, and do we do the best source? Can we use technologies to help? I mean, I keep thinking about projects, so I got to get the projects out of my mind. We're on indicators, so we just need to understand, just about what's there, and is it optimized for the community? Because these are the things that are going to help our care coordination teams do well. So that's why this question is here, just to give you a little bit of context of why we're asking that question. That makes sense.
Our other work groups have also named interpersonal violence. So not sure if folks were able to join the Board of Health a few weeks ago, but they had a panel discussion on domestic violence and its impact on health. So raising up some of those indicators that we are using to track domestic violence, interpersonal violence, as well as our work group, our health equity work group named the impact of discrimination and structural racism on health and thinking through and how to operationalize that. So just some additional ideas that your peers have previously named. And is everyone seeing the updated slide here of responses coming in for the social and community?
No, I think
context?
Taylor, we're seeing like the we're not seeing like it's not in presentation mode. It's like in the just actual, yeah, so I'm
Okay,
sure.
let me reshare.
And the only thing I want to add to my comments before, and I would be remiss, is to say get the data not only from the hospitals, but also from the health centers, the FQHCs. Add that to that list. Fortunately, they have UDS, which gives them a better sense, and they actually do a pretty decent job, our local ones, in examining their data, but making sure that they're at the table too.
Thank you for that, Judy. All right, is the slide updated for you all now?
No, it's the same.
All right, let's see here. I will just read off a few here. So we have WIRE BS data, students who have an adult they can trust to and talk about their issues, senior centers, measures of violence, community-based violence, green space, and the built environment, information that captured from SDOH assessments such as food insecurity, lack of transportation, stable housing, difficult getting medication.
There's another one, Till. I don't know if you see it, but I can read off for you. It says health behaviors, smoking, physical activity, social isolation and loneliness, nutrition, diet, education level, unemployment, crime rate, accessibility barriers such as transportation technology.
Tornisha. Anything anyone wants to elaborate on? And just in the interest of time and technology not wanting to work with me today, is everyone still seeing the poll on their end? Okay. Well, I will just open it up for discussion then. We had some other questions related to the neighborhood and built environment, economic stability, and access to quality education. So did folks have any thoughts that they just wanted to come off of mute and share? And I can put those in the chat as well.
It is really interesting that you mentioned quality of education. When my husband and I lived in Prince George's County, and our kids were much, much younger, the elementary school that was by our house that our children would go to had the lowest academic rating in the county. We looked at that. And that's when we decided to move, because we wanted to make sure that our kids had access to a good school. And so, I don't know if others do that too, but that was an interesting comment to hear that, because we actually did do that. And others may be also doing that, trying to understand what that looks like and what that means, particularly, at least as another data point in some of the areas that aren't so strong.
Thank you. Anything else for education quality, or again, the built environment, or discussing economic stability? And as Dr. Carter mentioned, these all compounds. So if you want to bring up another idea and see how it all relates, please feel free to do so as well.
And Tella, just back to the quality of education and some of the data, think looking at maybe like how many kids like receive free lunch, reduced lunch, how many have stable housing, to see like what is the impact on their grades or, like what are some of those driving factors to just look at, the test scores, the grades. So I think some of that type of data can play a part in, looking at the drivers for indicators for quality of education.
Thank you for that, Tornisha. And something that we've been paying attention to with the Wire BS data, they ask questions about student safety and bullying and all of those other factors that go into how one's access to education can be shaped. So paying attention to those as well, as early as middle school and seeing how folks, matriculate through high school and, then tying that into our local universities here, our community colleges, being able to see how that across the life course, across those early childhood years to those young adult years. And someone's added here correct numbers and address to places and direct lines to people instead of an operator. I'm curious, does someone want to expand on that?
Yeah. And I see Shanika says family dynamic.
And so again, seeing how all of these factors are very interconnected. And I think that's something that the state has done well, especially as it relates to youth factors, being able to take in all of these factors and in the home, in the schools, and all of the environments that they're in, and being able to tie those to health outcomes, what we're seeing in terms of behavioral health, what we're seeing in their physical health, obesity prevention, and being able to have that discussion and again, tell that story in the community health assessment. Was there anything else anyone wanted to add before we wrap up today? I will be sure to get out these Slido results. And if anyone has any ideas after today's meeting, feel free to email me. I can put my email in the chat. But is there anything else anyone wanted to add before we wrap up this activity? Well, thank you everyone for your participation. We appreciate the feedback and we will be continuing to do our research and locate where we can access all of your brilliant ideas and take this a step further as we build out the community health assessment. We will certainly be in communication as the CHA progresses and you participate as much as you can. So let me get our slides back here, Tornisha. I think we are ready to go on to our community announcements.
And again, as Taylor said, thank you for your participation, and we'll be sharing more information as we continue the process of completing the community assessment. And so now the community announcements. Can you tell our next slide?
Just popping some links here in the chat.
Okay. So good news, and thanks everyone for voting. We have a new coalition name. The name is Prince George's Health Action Coalition. So no longer healthcare, it's just Prince George's Health Action Coalition. So PGHAC. So again, thank you for your participation. We will have a new logo that reflects the new name. Okay. Also, there's a survey out by the Maryland Commission on Public Health. It's the deadline to do the survey is October the 31st, so a few days left. So please, click the link and complete the survey. And there's more information. I won't read it line by line for detail, but we'll be sending these slides out as well. And Tella also put a link in the chat.
Yes, and I'll just add really quick here on the Maryland
Yes.
Commission on Public Health Survey. This survey is collecting information about how folks utilize and understand health information. And so when we're talking about health literacy, that was something that got brought up today. We want to understand how Marylanders are consuming information. As you all know, there's been great initiative across the state to build out the state hub for health literacy. And so again, just understanding how are folks digesting information? How does this relate to the larger umbrella of organizational health literacy? So if folks can share this with your networks, please get this in the hands of as many Maryland residents as possible. We really want to make sure that we're capturing, again, how folks are consuming information, what are the gaps, and how do we take this and implement it in our practices, and it will impact everyone from our community-based organizations, our practitioners, our hospital partners. So we really want to make sure that this data is as robust and diverse as possible in the responses that we are receiving from across the state.
So please get it when you have a few minutes. Please make sure you complete the survey. We'll really appreciate it. And as Tella mentioned earlier, there was a panel discussion on domestic violence. The recording has been, we have a link to the recording. So please take a listen when you have an opportunity. And this discussion actually was held on Tuesday, October the 8th at the Curry County Administration Building. Okay, there's a senior health and wellness fair that's being sponsored by MedStar Southern Maryland Hospital Center. So if you'd like to be a vendor, please reach out to Jessica Gamero. I hope I'm pronouncing her name correctly. Her information is listed below, her phone number and email address. The health fair will be held at Clinton Baptist Church on Woodyard Road in Clinton on November the 23rd from 10 to 2. Okay, and again, thanks for attending this meeting. So our next CCT monthly meeting will be held on Thursday, December the 12th at 11. Look forward to seeing you all there. We will also have our Prince George's Health Action Coalition in-person quarterly meeting on Tuesday, December the 10th from 6 to 7:30. So these are our next upcoming meetings, and information will be sent out regarding the meetings. So again, thank you again for participating, and we look forward to seeing you at both meetings. So I'll hand it over to Dr. Carter, our Teller, or Caitlin to see if they have any final words.
Just make sure you're taking a look at this updated date. Our next CCCT meeting that was scheduled for November is going to back up right to Turkey Day. So we want to give everyone that observation. So we will be bumping the meeting back. We're going to cancel our November and December meeting and instead have a combined meeting on Thursday, December 12th at 11 a.m. I will adjust the meeting invite to have on your calendars. And then also communicate with you all about our in-person quarterly meeting happening December 10th as well. Are there any other community announcements or anything anyone would like to share before we wrap up?
No, I think we're good. So I appreciate all the input and thank you guys and you all have a great weekend.